Hello all. Welcome to this webinar titled Seasonal Malaria Chemoprevention in Nigeria Amid COVID-19, organized by Science Communication Hub Nigeria and National Malaria Elimination Program of Nigeria. I'm Dr. Jamil Ibrahim Miko from the National Malaria Elimination Program. With 11 million cases and over 500,000 deaths due to COVID-19, the pandemic had disrupted all aspects of human endeavors globally. It has led to medical supply shortages, declining utilization and provision of health services and healthcare resources. According to UNICEF, a total of 99 countries reported that the suspension of childhood immunization services of many life-saving vaccines in May. In a survey of more than 100 countries, more than half of them reported partial or complete resumption of hypertension treatment. 49% reported so for treatment of diabetes, and 42% for cancers, and 31% for cardiovascular emergencies. The UNDP, in its Global Socio-Economic Impact Assessment on COVID-19, estimates that 40 to 60 million people will be pushed into extreme poverty. 1.8 learners are affected by school closure, and about 1.6 billion informal workers lost 60% of their incomes, with little or no income and no access to social protection. The World Bank forecasted 42% contraction of the global GDP. The malaria is one of the most important public health challenge in Nigeria. Despite significant reduction in the malaria burden in the country, with its prevalence down from 42% down 23% from 42% between 2010 to 2018, Nigeria contributes to 20% of global malaria cases according to 2019 World Malaria Report. Key interventions adopted by Nigeria for the control of malaria include the use of long-lasting insecticidal nets, indoor residual spraying, seasonal malaria chemoprevention, intermittent preventive therapy for pregnant women, and effective case management, among others. Malaria is also not spared by the coronavirus. In a worst-case scenario, in a modeling study conducted by the WHO on the impact of COVID-19 pandemic in sub-Saharan Africa, deaths due to malaria will increase by 100% to 150% if there are no airline campaigns, no continuous airline distribution, and access to effective malaria anti-malarial case management is reduced by 75%. We have a distinguished panel that are strictly observing the social distancing protocol to discuss SMC and how it can help in reducing malaria burden in Nigeria. You can also participate by putting down your notes in the comment section of the medium you're watching us, either Facebook, YouTube, or any of the channels. The panel will also answer some of your questions on the subject matter. We have with us Dr. Godwin Nadom. He's having some network problem, but will soon join us. He is the Chief Consultant Epidemiologist in the Federal Ministry of Health and the Program Director of the Nigerian Field Epidemiology Training Program. He had worked with the National Malaria Elimination Program of Nigeria for over 2 decades and served as the head of case management in the program. We also have Dr. Linda Ozo, the Malaria Program Manager in WHO Country Office in Nigeria, Abuja. The third panelist is Dr. Lawal Aliyu Rabeh, the Director of Malaria and Sickle Cell in the Katsina State Ministry of Health, to have perspective from the state. The last but not the least is Dr. Enina Ogolafo, the head of case management in the National Malaria Elimination Program of the Federal Ministry of Health. So to start the discussion, Dr. Nadom is with us here. I think he has resolved his network issue. I don't know, Dr. Nadom, can you hear us? So maybe let's start with Dr. Linda. Dr. Linda, are you with us? Okay, Dr. Nadom, let's start with you. Maybe can you just give us a brief overview of the COVID-19 situation in the country to begin with? He seems to be having the same network problem. Or maybe let's start with Dr. Ogolafo. Dr. Ogolafo, how does the COVID-19 affected work at the National Malaria Elimination Program?
Thank you, Dr. Jamilu. It's a pleasure to be here to participate in this very important discourse. So, going to your question, how the COVID-19 has affected work in NMEP, um, I mean, it's all like very obvious, you know. If I could start by talking about the anxieties and the fears that everybody had with the onset of this pandemic, you know. So generally, people's morale were low because this was a novel virus coming in for the first time with a whole lot of mortalities and morbidities. So that alone affected work, you know, at the NMEP and across board anyway. And then coming down to the decisions taken by the government, federal government of Nigeria, to mitigate the spread of the virus, which included the lockdown situation, meant that a whole lot of our activities was brought to halt too. You know, most of our activities at the program are done, you know, in person, you know. So you have to be there to do your monitoring of interventions we're doing, you know, with the states, even at the federal level. So that was a big issue for us. And then most of us had to now go online, you know, doing our meetings, you know, the much we could do. Like I said, the physical activities were off completely because of the lockdown. And then a whole lot of us had to go online doing our meetings and stuff. And you know, in Nigeria, the epileptic nature of the electricity and also the internet, you can see it's taking Dr. Nadom a whole lot of time to log on, you know, and be steady with his internet. So those, you know, this has been issues, a whole lot of issues. But it's good to note that we've been able to surmount all these challenges, you know. So we've bounced back and we're doing great, I would say. Over.
Thank you very much. Thank you very much, Dr. Gulafo. So maybe let's go to Dr. Nadom. Can you give us a brief overview of like the COVID situation in the country?
Well, thank you very much. COVID situation in the country is, we won't say alarming. When we compare it with what is happening in some other countries, we still commend ourselves that the country is doing relatively well. Like the way it is now, we've recorded some mortality, but like I said, the case fatality rate is still below 2.3%. That is not what we have elsewhere. We have 5% in some places. We have as high as 8% in some other countries in Africa. But Nigeria has been able to surmount this major challenge, though we won't be praising ourselves for now because we are still, the transmission is still increasing. We are trying our best to see what we can do to bring the whole situation under control.
Thank you very much, Dr. Nadom. So let's go to Dr. Lawal in Katsina State. So how is SMC affected work in your ministry, in the Katsina State Ministry of Work, especially regarding malaria prevention and treatment services? Dr. Lawal. Dr. Lawal, can you hear us? Or maybe let's move to Dr. Linda. I think we'll be discussing SMC, seasonal malaria chemoprevention, and it's an intervention that is approved by the World Health Organization, WHO, the organization you work for. So what is this SMC? Who can benefit from SMC? Where and how can this, where and when can this SMC be delivered? Dr. Linda?
Okay, thank you very much, Dr. Nicole. SMC, for short, it's a seasonal malaria chemoprevention, and it's by definition an intermittent administration of full treatment courses of an anti-malaria medicine to children aged 3 months to 59 months who live in areas of highly seasonal malaria transmission. This seasonality coincides with the rainy seasons. And so in Nigeria, for instance, we have the far north area where the rain pattern is limited to 3 to 4 months in a year. And so these areas have initially been highlighted as being eligible for the seasonal malaria chemoprevention. Understanding that the aim of the seasonal malaria chemoprevention is to prevent illness by maintaining a therapeutic level of the medicine within the bloodstreams of the children throughout this peak period. That way, it mitigates, it further prevents them and protects them from getting the disease. And so looking at, you asked who benefits, and so I've mentioned who benefits. That's children aged 3 to 59 months living in areas of highly seasonal transmission. So in Nigeria, largely for the past years, we've implemented in the Sahel belt, even though I know that going by the clear definition and eligibility for SMC, one of which is areas where more than 60% of the malaria clinical cases are recorded within this 3 to 4 months period. And so it means that we are also looking at other areas that may meet this criteria beyond those within the Sahel belt. Thank you.
All right, thank you very much, Dr. Linda. I saw Dr. Rabeh, Aliyu, Dr. Lawal, are you with us? Can you hear us? Dr. Lawal, can you hear us? I think he seems to be having the same network issue. So maybe let me go straight to Dr. Ogulafo. So now, as Dr. Linda told us that the SMC is for children between 3 months to 59 months, that's under 5 children. So how will a child in an eligible area, I think she told us that not all parts of the country are eligible, how will a child in an eligible area receive SMC during the campaign? So Dr. Ogulafo, can you tell us so that those eligible can know?
Okay, yes. So thank you for that question. So the children would usually, SMC is a very well planned out intervention, like every other intervention we have. So we also need to know that it's a community-based intervention. And so we have the community drug distributors, we call them the CDDs, whose job is it to go from house to house to give these medicines to these children. Okay, so what they do, and they do this under what we call direct observational treatment method, that is the DOTS. So they get to the households of the eligible children. Mind you, before this time, there's usually, a kind of advocacy that goes on, enlightenment program within the communities that are going to receive this. So there's a whole lot of advocacy that is kick-started before the activities, the mass drug distribution itself starts. Okay, so that the mothers, the caregivers are aware of what they are supposed to do and how they are going to cooperate with the community drug distributors. So, like I said, they go house to house, to distribute these drugs under direct observational treatment, at in dots. They observe them, they give them the drugs, the medications, and they observe them take it to make sure that they are taking it. And also part of what they do is to teach the caregivers how to give the day 2 and day 3 doses, making sure, going through with them that, they've understood how to give these medicines on the 2nd day and the 3rd day. And, with this COVID-19, we've worked so hard to make sure that this very good intervention is also implemented in line with the preventive measures, with the COVID-19 measures. So these CDDs are going to be giving out these drugs, observing the social distancing, and not, observing the minimal contact with the caregivers and the children. So this is obviously to minimize infection, just in case you have such. And it is good to mention quickly at this point that we also have done a lot of collaboration this time with the COVID, with the NCDC, to integrate some messages regarding the COVID-19 together with this intervention. Thank you.
All right, thank you very much, Dr. Oglafo. Maybe the next question, Dr. Lawal, can you hear us?
Yeah, I'm getting you.
Hello, good evening. It seems you are having some network issues. Yes, we can hear you now. So maybe let me post here questions and say my other questions to you is that how does the COVID-19 situation affected malaria prevention and treatment services in Katsina State?
But I'm getting you.
It seems he's having the same problem. Maybe you can answer the questions when you sort out your network issue. So maybe let's go to Dr. Nadom again. You are the head of case management when SMC was introduced in Nigeria. You rolled it over in some states. You rolled it out in some states. So maybe can you tell us a brief journey of SMC in Nigeria and maybe the expected benefits to caregiver to those children under 5? Why give them the SMC?
Thank you very much. I think maybe we sometimes when it becomes easier when you mute your camera to talk so that you will hear it more, because it's a network thing, and when it is audio alone, I think it is clearer. Can I try it? Okay. Thank you. The SMC, the journey started as far back as the year 2008, when we had a meeting in Dakar, Senegal, which was actually trying to promote the seasonal malaria chemoprevention across the country, especially the Sahelian countries. So the Sahelian countries are quite a few of them. All the countries that were involved were invited to that meeting, which include Senegal, Gambia, Mali, Burkina Faso, Niger, Chad, Guinea-Bissau, Ghana, and Nigeria. And it was like it's a stretch. The Sahelian region is across all this country, and after that meeting, it was generally agreed that it can be, it could be adopted as a strategy. And in 2011, WHO brought out a clear guideline on the implementation of the strategy. And Nigeria, if you consider Nigeria flowing through the Sahelian region, you have about 8 or 9 states that fell into that region. And the first test was to consider the medicine that was to be used, which was the SPAC, that is sulfadazine, pyrimethamine, and amlodipine, whether it will be sensitive in the region. Assessment was made to show that sulfadazine, pyrimethamine was still okay in the region. And based on that, Nigeria was one of the countries that adopted it. I must tell you that the journey has been beautiful. If you consider the malaria situation in Nigeria, you discover that most deaths actually occur in the northwestern and northeastern region of the country, because that is where you have the prevalence of the disease being very high. And in that situation, if you narrow it again down, who are the vulnerable population in this region? They are the pregnant women and the children below the age of 5 years. And it was a welcome development for the strategy to be adopted. We had some partners that actually supported at that initial stage. One of them is Malaria Consortium that came in strongly. We also have WHO coming in with a strategy with support, and many other supporting agencies. But the challenge we had is that it has never been fully implemented in this region. We have several local governments falling into this category. We have a population of about 11 million children to benefit from this strategy. But unfortunately, I'm not sure up to now we've been able to cover the entire local governments that are expected to benefit. But it has been demonstrated that in places where this strategy was adopted, they have gotten a very good result. So that is just a brief background of what has happened. And also, I will not forget Chai also plays some role in supporting and UNICEF. Thank you.
All right, thank you very much for this very brief historical background of SMC. So maybe what are the benefits like for the children that will get the intervention for SMC?
Yes, it's actually very beneficial to these children because now, if you look at this region, they have a lot of challenges with diseases, not only malaria. They are equally exposed to malnutrition, ARI, and it was thought that when you remove malaria, the problem is not only halved, but a whole lot, because malaria will contribute to the malnutrition. Malaria will equally contribute to all other challenges, like when you see a child having malaria, if it progresses to severe, they come down with condition that simulates acute respiratory tract infection. So coming to work on malaria, like in a study that was carried out by Access MC, Malaria Consortium and CHAI, it was discovered that when these strategies were introduced, or the strategy was introduced, there was actually a reduction in mortality in this region. And if you can look at it, if you look at the 2019 or 2018 National Demographic Health Survey, you will see, and you compare it with the past, you can see some impact of this strategy in some of these states, especially where it was implemented, like Katsina State. Unfortunately, Katsina State, the initial implementation was 4 local governments out of the 34 local governments in Katsina State. And we had a promise from the permanent secretary then, who said he was going to support in escalating it to other local governments, but unfortunately, it didn't happen. So largely, we still depend on partners to carry out this intervention. We even went along the line of bringing all the honorable commissioners of the 9 states to Abuja to discuss with them on the need to put resources into it, but unfortunately, still the same story.
All right. Thank you very much for the historical background and the benefit, as well as some of the serious challenges we are having on SMC in Nigeria. So maybe the next question, I'll go back to Dr. Linda from WHO. We are aware that WHO is supporting, this year will support Borno State to implement SMC to cover all the children that can be reached in Borno State. So now Borno State being a complex operating environment, so how do you plan to navigate your ways so as to reach all the eligible children in Borno State? Dr. Linda? You can unmute yourself. Dr. Linda, unmute yourself.
You are muted, Dr. Linda. Okay.
Okay, I was trying to unmute myself. I'm sorry. So yes, yes, Dr. Nikal, thank you very much for that question. Indeed, Borno is a very challenging environment. It's a complex operating environment, and like you rightly noted, WHO will be implementing SMC in Borno State this year. And it's not just this year. Even at the height of the insurgency in 2017, that was when the emergency response and alert system, surveillance system, alerted that malaria, more than 50% of the deaths in Borno State were due to malaria, in children under 5 were due to malaria. And so we needed to move in to save the day. And so in collaboration with the State Ministry of Health, we were able to develop a guideline that was context specific to aid us implement in such an operating environment. And so having reached in 2017, we were able to reach 1.2 million children with SMC. That was unprecedented given the situation. And so far, we have also supported the states and other partners who are implementing SMC across other states. This year specifically, from the generosity of the Global Fund, WHO
Okay, Dr. Linda, are you with us?
No, I think it's the network.
Okay, it's the network. Maybe we should continue. Maybe
to mute the camera.
Has been also approached to support.
Okay, Dr. Linda, you can mute your camera. You can switch off your camera if you're speaking. So maybe whenever somebody is speaking, you can switch off your camera so that.
It's not a camera issue because I'm using my phone network. So a call came in and it interrupted the.
Okay.
Yes. Oh. Yeah. So as I was saying, rightly mentioned, Borno is a complex operating environment, and because WHO leads the health partnership in Borno State, we have been working not just in malaria across other health areas in Borno State. And even before the insurgency, Borno was one of the states that where they had intense surveillance for the polio eradication. And so it meant that we had always used the human resource structure, the governance structure in the states, drilling down to the communities, which is what we may acclaim the polio eradication certification to. And so looking at that, we will be using the same structure that the polio teams have used to navigate through the systems. We know that in Borno State, we have categorized access in 3 major areas. So we have fully accessible areas, we have areas that are partially accessible, and we have areas that are totally inaccessible. So for the 2020 SMC, we will be going to the 25 out of 27 LGAs. 2 LGAs are totally locked out. They are inaccessible. But with the other LGAs, we plan to reach the nook and cranny using the different, a combination of methodologies. So we are going to deploy through a door-to-door campaign strategy. However, we know that there are also breakout teams, like in the emergency teams, polio teams. There's something we call the hard to reach teams. These teams also get into the hardest to reach communities through mechanisms that have been framed up with the State Ministry of Health. Also, in the state, we work in collaboration with the Joint Task Force to make sure that the communities are involved and that we have some sort of protection for those health workers who will be delivering services. One thing about SMC is that it requires huge human resource capacity. And so it's not something that can be mobilized from outside. It means that you have to leverage on the human resource capacities that exist within the communities to be able to deploy SMC effectively. And this is exactly what we're going to do. Thank you.
All right, thank you very much, Dr. Linda. I think these strategies will significantly reduce the deaths in Maiduguri, where the conditions are actually very there. So my next question will be to Dr. Oglafo. The NMEP plans to scale up the implementation of SMC significantly this year, and then come the coronavirus pandemic that disrupted virtually everything. So are you still going ahead with your plan to implement SMC in all the 9 eligible SMC states, or how do you want to do SMC this year? Dr. Oglafo? Dr. Oglafo, unmute yourself. Sorry, before you start.
Yes, thank you. Thank you, Dr. Jamilu. So, yes, we're going ahead to implement as planned, just like Dr. Nadom mentioned earlier during one of his question when he was answering one of his questions, he made mention of scaling up. So yes, at the program, we have scaled up significantly. As at 2019, we covered up just about 6 states, and that 6 states wasn't a full coverage, but this 2019, we have in mind to cover all the 9 Sahelian region states that are in the country, and that's at full scale. Apart from Borno, Bauchi State, where we're leaving out 10 LGAs just maybe because of funding constraints, because like we've all noted, the intervention is a very impactful one. So we're working hard to see that we are having a full coverage in all the states that required are eligible for this intervention. And the pandemic, with the pandemic that has come on board, there has been a whole lot of challenges. But because we know also that the pandemic has similar symptoms with malaria, and we know what that implies. So we've been very consistent, and we've made strong efforts to make sure that the scale up that we have planned for 2019 is at as planned. So it's good to, I'm happy to mention and to say to everybody that we've been able to have a full coverage for 2020. Plans are all set for it. You can even see that Borno State, we have also come on board for Borno State for this year. So we're covering all the 9 Sahelian states, and notwithstanding with the pandemic, we've worked, very strongly and seriously to make sure that this is not deterring us. Thank you.
All right. Thank you very much, Dr. Oglafo. Dr. Lawal, can you hear us so that we can hear from you? Dr. Lawal, can you unmute yourself so that we can hear you? Dr. Lawal, Rabeh from Katsina, I think he seems to be having the same network issue. So maybe let me go to Dr. Nadom. So now for SMC, it's usually implemented as a campaign. We deploy these interventions to millions of children in Nigeria. Over 10 million children will be reached this year, and we'll be giving them medicine monthly for about 4 months. So how safe are these medicines so that to allay the anxieties of parents and caregivers, so that to know that it's safe to give their children these medicines? Dr. Nadom? Okay, you can unmute yourself, Dr. Nadom.
Sorry for the... Initially, before the adoption, that was a major challenge. People were not too sure, but I must tell you, sulfadoxine-pyrimethamine is a very safe therapy. And the initial fear was that of the what they call the Stephen Johnson syndrome, that the toxic epidermal necrolysis also. But unfortunately for us, is a very rare manifestation amongst the blacks, especially people in Africa. The results that the evaluation shows about it is 1 in 25,000 to 1 in 35,000 people. So it is very rare. Definition of rare in WHO is when 1 occurs in 10,000. Very rare in WHO is when 1 occurs in 10,000. But this one is 1 in 25,000 to 1 in 35,000. So it is a very rare occurrence. So sulfadoxine-pyrimethamine is very safe. And when you come to amodalquine is a medicine we've been using. It's just a moiety of chloroquine. So it's been in the system. Many people are used to it. But the good thing is that it's still sensitive, very sensitive. So the medicine is very safe. And it's also found that though there is some side effects with the use of amodalquine, like you have dystonia and many other manifestations. But it's also been studied that it does not occur in children that are very young, that is, children that are less than 5 years. So they don't manifest with all those side effects. So when you combine sulfadoxine pyrimethamine and amlodipine, it is a relatively safe medicine for the children. So it does, and using it 4 times or 3 times in a cycle does not really give any serious condition. So it is safe and well tolerated by children.
All right. Thank you very much. I think this would allay some anxiety from caregivers. The medicines are safe. We've been implementing SMC since 2013 from Katsina State up to 2019. Millions of children have received SMC without any serious side effects. So if SMC will start implementing SMC this year in your state, so that you should not feel anything. You should give your children so that they will benefit from the intervention. So since if Dr. Lawal can hear me, can you answer the next question? What's your experience SMC implementation in Katsina State, especially regarding maybe acceptability and then the impact of SMC in malaria reduction in Katsina State? Dr. Lawal? Dr. Lawal, can you please speak?
Maybe he has muted his speaker.
If you are muted, can you unmute yourself and speak? I think he's still having the network issue. So maybe let me move to Dr. Linda. So Dr. Linda, what are the social mobilization strategies you are adopting to ensure SMC reach caregivers of all children that are eligible and they adhere to the treatment course, the 3-day treatment course for them to get the full benefit of SMC, especially in states that you're supporting?
Okay, thank you very much, Dr. Nikau, once again. Dr. Bula, for during her first response, did mention that SMC is implemented through a DOT approach, and then the 2nd and 3rd day regimens given to the parents or the caregivers to make sure that they adhere and comply to the full treatment dose. And so it's necessary to ensure that people and caregivers adhere to these, treatments dosing. And so in terms of mobilization, we are deploying all kinds of mobilization strategies, again, that are context specific. We are engaging the State Ministry of Health, the state health educators, and the community leaders, the traditional leaders, the community leaders, the World Development Health Committees. Everyone is involved to make sure, first of all, that people are informed of the benefits of the SMC, that people know when SMC will be happening, that people know what the expectations are, and that the teams who will be going from house to house are also aligning with the expectations of the people. As you know, as a public health person, you would know that acceptability is key, very key to the success of any intervention. And so for this, in terms of mobilization, we have a risk communication plan that sort of engages the community members through IEC, interpersonal communication, and also the use of various communication media channels. We have communication strategies where we have mapped out different methods of communication and of reaching the people, regardless of where they are. And so it means that we are having to tailor our communication strategies to every individual situation. Because in Borno State, as you would know, they have the IDP camps, where it's a closed community and people tend to have a certain way, regimented way of doing things. And then we have the affected host communities who are hosting the IDPs, who have been affected by the displacements, but are living within their own homes, but are also experiencing similar hardships that the displacements have caused. And so the interventions are targeted to make sure that every category of person within these communities are reached with appropriate messages and are mobilized, told when the SMCs will happen, what to expect. And when the teams get there, they also take time to educate every family on the benefits of SMC, what to look out for, as I think it was Dr. Nadom that mentioned earlier. When a child is sick already, that child may not be able to benefit from SMC. So there are little operational issues that need to be communicated. So the people do not think, oh, why are you giving to, I have 6 children, one is 7 years, and the others are less than 5. Why are you giving those people and you are not giving the other people? So you need to manage expectations, inform the community, and also work with the community to make sure that the campaign is a success. And only with their engagement, the engagement of the community, the government, and all the stakeholders will this thing succeed. We're also working with the health partnership in Borno State. Within the humanitarian space, there are about over 12 health partners working that have interest in malaria. And so they're also coming together to support the SMC campaigns. Part of that health partnership is also providing the operation center for the day-by-day involvement and engagement on the, once the campaign starts, the operation centers will be activated. And these emergency operation centers will make sure that there's timely resolution of bottlenecks, there's timely recording of data, there's timely resupplies of commodities in case commodities within the fields are exhausted before the end of the day. And so these are the way the structures that have been put in place to make sure that we have a seamless activity. This is how we've deployed in the past years, and I think this year is going to be a huge success. Over.
All right. Thank you very much, Dr. Linda, for this robust response. Dr. Lawal is back again. I don't know whether he has sorted out his network issue. Can you hear us? Can you just speak to us, Dr. Lawal?
Hello, Chief Dr. Milu.
Yeah, okay. Thank God we can hear you now.
Hello?
So maybe, hello, can you hear me? Hello?
Yeah, I'm getting you.
Okay. So I'm wondering if you can just maybe give us maybe what's the experience of Katsina State regarding SMC, especially regarding the acceptability and then the effectiveness or the efficacy of the impact of SMC in malaria reduction in your state.
Well, to Alhamdulillah, we can say the impact and the acceptability are quite appreciable among the population of the state. But you know, we've been
I think his network went off. His network went off again. Maybe let's just that's allowed. Maybe hello. We can't hear you, Dr. Lawan. Maybe just mute yourself. We can't hear you.
His network is really bad.
Yeah, it's bad. Let's just mute yourself. Maybe let me go to Dr. Ogulafo. What will be different in the way NMP will implement SMC post 2020? Maybe Dr. Lawan, just mute yourself. We'll come back to you later. Dr. Ogulafo, can you go ahead?
Okay, so thank you, Dr. Jamilu. So what will be different? I think I prefer to switch off the camera because the internet is so bad, even from my end here. So, this year we are going to scale up. Like I said, we're doing all the 9 Sahelian states. So we're having almost a coverage of over 11 million children. So that is really huge, and we're happy. And we're happy that we're going that we've been able to scale up to that level. So we're going to definitely look at lessons learned from this year. This year being peculiar too and unique because of the COVID pandemic. So at the end of this year's implementation, we're going to really sit down to look at lessons learned. Lessons learned will also include things that we've learned, having to do this intervention under this kind of situation like the pandemic, and also having scaled up to this level. Because by 2020, we're also going to have scale up further, to the other northern states, like Dr. Nadom also mentioned in his earlier brief. So we're going to scale up to some of the other northeastern and central part of the north. So we are really going to look at what we have learned and then apply it across board. It's also important to note that the recent stratification exercise that was done, had enabled us make this decision to scale up this very impactful intervention to the other northern parts of the country that is also having some not very good statistics in the malaria space. So definitely we will look at what we have learned and apply it across board. Thank you.
All right, thank you very much, Dr. Obulafo. Maybe your audience, if you have any question on SMC or maybe regarding malaria case management, you can post it on the comment section, and I'm very sure our panelists will be happy to answer your questions. So maybe let me get back to Dr. Nadom, especially this one. I will go back to the COVID-19 pandemic. As you are aware, the COVID-19 cases in Nigeria are increasing, and it seems people are tired of strictly adhering to preventive measures against the virus. Can you give a word of advice to the public on this? Maybe if you can unmute yourself, Dr.
Yes, I have. Thank you. The initial fear was getting to the community, but unfortunately, we eventually got to the community. When you have community transmission, what it means is that you don't know. The first step when it all started, people who came into the country were the people carrying the virus, and those people were tracked, and all their contacts were traced. But now, when it becomes a community infection, you don't even know the sources. Somebody goes to the market, you contact it, you go to supermarket, you go to school. So it's a major challenge. And now, talking about SMC in the context of COVID-19, where we are talking about community, the PTF, as it were now, will not allow any community gathering. So the best approach will still be the house to house. Because in the past, other methods, posts, where you create posts, distribution posts were adopted. But now, the house to house, but even the house to house, you see how to has a lot of caution. The caution will include the situation where when you go from one house to house, are you sure you are not picking the virus from one house to another building? Because now that may not be acceptable. So what we have to narrow, we have to now begin to go in such a way that when we move out, sorry, I think the mic is coming back. Somebody, you have to mute your something, Dr. Jemilu, because it's coming back to me. Hello? Can you hear me now? Helsi. So, yes. So, doing house to house, the initial fear is that I hope you are not going to go to one house, collect the virus, and take it to another house through contact. So how do you plan that? That is to do, since it's not going to be a handover that you are going to take it in a pack and give physically, because that may raise questions. How do you ensure that there is no contact at all? There's no physical contact. You begin to plan along that strategy, because in some areas, especially in some parts of the developed world where food are distributed at homes, what they do is that they put it in a pack and drop it. They don't give it. Dropping means there's no physical contact. It's either we begin to look at the strategy we are going to adopt, where there is going to be almost zero physical contact. If not, some people may raise eyebrow, and going to cover millions without having that contact is a challenge. And we have to equally observe all the precautionary measures, the respiratory etiquette. Everybody must wear masks, especially the distributors. Everybody must go with sanitizer after you give to to a house, you have to use your sanitizer. Everybody must also be sure, because it is important. Now, tests are not, I must say, they are not enough to ask people before you commence that all of you must go for tests. No, it may not work out that way. That means everybody is going out blindly. You don't know whether they have the virus or they don't have the virus. And we are also very careful of medical legal action, where some people will wake up one day and say, okay, I went to distribute and I came back with the virus. Or I went and somebody in the house will say, oh, the people that brought the medicine were the people who gave us the virus. So we have to begin to think through all these challenges before we set out to move to the field.
Thank you very much for this expert advice from the Chief Consultant Epidemiologist of the country, Federal Ministry of Health. So maybe Dr. Lawal is around. Maybe let me once again give you opportunity to share the SMC experience from Katsina State. Hope his network will be good this time around. Dr. Lawal?
Yeah, good afternoon all. Yes, please, Dr. Jamila, I'm getting you. I getting me?
Unmute yourself, Dr. Jamilu.
Okay, no problem, Dr. Lawal. I think the network problem is still there, so no problem. Let's just proceed. We have a question from our audience. This question is from Abu Mena, who joined us using Facebook. He said that it is said malaria and COVID-19 have similar symptoms. Hence, this make most people to refuse treatments due to fear of COVID-19. What solution do you propose to assure people not to fear any of the disease? So maybe any of our panelists can answer this question.
Well, maybe I should just attempt. One thing I want the public to know, that SMC is not a treatment. You are not going for the people that are sick of the infection. It's a preventive measure you want to give to the children so that they don't develop malaria. So everybody is entitled. You are not going to look for people who have symptoms. You are actually going to give them medicine so that they don't develop symptoms and sickness as well.
Okay, just to add to what Dr. Nadom has said, because of the fears of COVID-19 and because we know that it has very similar symptoms with malaria, this is even the reason why we are saying people should abide by the preventive measures. And the SMC, like we've discussed at length, also is one of the preventive measures for under 5 children. You know, so we're saying that caregivers should please make their children available and make themselves available so that the children can get this intervention, which is preventive based. Prevention means that it's going to prevent them, from having malaria. Statistics has it that 75%. It confers 75% preventive will I say measures to malaria. That sort of 75% of possibility of the possibility of not having malaria is there when you have taken SMC. So we're appealing that people should not they shouldn't be so forthcoming with fears, rather embrace it with the fact to avoid malaria, so that they have less chances of going to the hospital for any form of treatment, especially knowing fully well that malaria is one of the very common diseases that take our people to the hospital. Also, sleeping under the insecticide-treated nets is another preventive measure that we're also saying that people should abide with, especially this period. Thank you.
All right, thank you very much, Dr. Oglafo.
Dr. Mikhail, maybe just to add to that, this links very closely to the question you asked on the mobilization. It is important that while we're rolling out this intervention, and WHO recommendation was very clear, that any intervention that has to be rolled out in this season has to ensure, one, that the people, the communities are not put at risk, and two, that the healthcare provider is also not at risk. So it's important that during the social mobilization, the communications, that people are informed and engaged on what SMC actually is. Like Dr. Nadom said, it is not a treatment. It's not, in fact, people who already have symptoms should be excluded from receiving SMC. They should go to the hospital, get tested, and if it is malaria, they are treated. So the issue of treatment or symptoms may not come in that much, but it's important to note that yes, the symptoms are similar, but it's important for us to make sure that the communities are well educated and informed on what SMC is and what the expectation should be. Thank you.
All right. Thank you very much for your response. I think the Abumena will be convinced with the response. So maybe thank you very much, panelists, for this very interesting discussion. So maybe to cap it off, if I may summarize the discussion in the last 55 minutes. SFC is one of the interventions adopted by the National Malaria Program in collaboration with our partners and state malaria elimination programs in the northern Sahelian states for the prevention of malaria in children under 5, specifically children between 3 months to 59 months. It's an intervention that was approved or recommended by WHO after years of careful research, and it has been proven to reduce malaria episodes in children that take the medicine correctly by up to 75% reduction of malaria episode. And even in those that have malaria, SMC can prevent approximately about 75% of those children from having severe malaria, the dangerous type of malaria that usually kills children. And it's also proven to reduce child mortality. And SMC is also proven to reduce anemia, that is loss of blood, because malaria is one of the commonest causes of anemia in children that are infected. And also, as alluded by our panelists, SMC is safe and serious adverse events have not been reported and are probably there. So on behalf of the organizers, I want to sincerely thank our panelists, for our distinguished panelists for the insight they provided on SMC and COVID-19 in Nigeria. And also want to thank our audience for their robust engagement and their beautiful questions. The conversation is getting more interesting, but however, we have to draw the curtains now. So thank you very much, our panelists. We hope you will honor our invitations when we invite you again. And also thank you very much, our audience, for your active participation. Thank you very much, and bye-bye.
Thank you very much. Bye.
Thank you very much, the moderator.
Thank you.